Hello and welcome to 15 Minutes with Longevity, your weekly dose of health news, reviews and the latest technology in medicine. I'm Giselle Wertheim-Ames and I'll be your host today. On the show we'll be speaking to Dr Sarah Rayne, a specialist surgeon who operates from Milpark Hospital, Helen Joseph Hospital, as well as Rand Clinic, and Dr Georgia Demetriou, an oncologist from the Donald Gordon Medical Center, as well as the Charlotte Maxeke Academic Hospital. And we're going to be talking about breast cancer and reconstructive surgery in post-treatment. I'm going to start with you, Dr. Demetriou, just to talk about where we're sitting with the whole issue of cancer and whether or not we're seeing a positive growth curve in terms of the reduction in the treatment of cancers in South Africa.
Well, an interesting international statistic, in fact, is that we are diagnosing more and more breast cancers. And that is because we have such a good surveillance system in place. We are seeing more and more patients. However, our mortality rates have gone down. And I think that's really the encouraging part, is that even though we are seeing more and more breast cancers, because we're diagnosing them earlier, mortality and death rates from breast cancer are going down. And I think that's the huge positive going forward. Breast cancer, any cancer, is not something to be scared of if we can pick it up early. And if we have early pickup, we have a far, far better chance of cure.
And I mean, that's very interesting because cancer evokes quite a lot of fear, I think, in people. And I think a lot of the research shows that people just always have this fear of going to check, even if they know that there might be something not quite right with their systems.
Absolutely, and I think that's the thing we need to get past, and that's why Breast Cancer Month, Breast Cancer Awareness Month, October, is such a huge move forward. It destigmatizes breast cancer, destigmatizes cancer in general, and it makes it easier for people to say, well, we're having a day when everybody in the office is going for a mammogram, everybody over 40 is off, we go for a mammogram. And it allows people to have less anxiety around it potentially, and especially in patients where there's potentially a high risk in the family, we need to basically take away the fear and say early pickup is in fact cure. And it's important, especially if you feel a breast lump, don't allow a healthcare practitioner or a primary care practitioner to say to you, well, you're too young or it's not likely. We're seeing breast cancers in younger age groups as well. And even though it's not likely to be a cancer in a much younger age group, sort of in the 20s, it's not impossible. So if something just doesn't feel right, rather go and in the early sort of age group have a sonar. Don't necessarily have to have a mammogram, have a sonar. And if you pick up something that's worrying, that can then be basically investigated, and that can be a much earlier pickup for you.
Now, we do speak about breast cancer almost being, it's the most visible probably of a lot of the cancers. And it has this profound effect on women and men, because I think a lot of people don't realize that men actually get breast cancer.
Absolutely.
Does that detract a little bit from the entire story of cancer, and that maybe, again, because we focus a lot as media and generally on breast cancer, that some of the other cancers don't get the kind of exposure or awareness that they should be getting? And which ones should we be looking at?
I don't think we should take away from breast cancer, because I think it's an important initiative that it is out there and that people are aware. It is the most common breast cancer, well, it's the most common cancer we're seeing in women, in fact. It's seen about 1% of males, but it shouldn't take away from the fact that we should be screening for other cancers as well.
How often should a man? At least with women, we now have some, we have the context to which we know when we have to have examinations, pap smears, have mammograms, or just daily checking. But with a man, again, these types of cancers, that really requires a visit to certainly a specialist, one would assume.
Well, if there are symptoms, then obviously go and see your practitioner. So from a prostate point of view, if you're having problems passing urine, go and see a healthcare practitioner, let them investigate, let them look for something. If you have any stool in your with blood, you should go and see someone and let them know. But we should have a screening program from the age of 40 for males in terms of prostate cancer, and in fact for the entire population from the age of 50, patients should go, or people should go, for a screening colonoscopy. If there's a family history, then the screening needs to start about 10 years prior to the index case. So if someone in the family presented with a colorectal cancer, say at 50, screening in that family should probably start around about the age of 40. So we need to increase awareness of all cancers. pap smears, most ladies go for their regular pap smears.
Sure.
But even there, we maybe need to move away from just screening, and we need to talk about cure and prevention. And for cervical cancer, there's the HPV vaccine, which can be started in patients prior to them becoming, or young girls prior to them becoming sexually active, and that can reduce the risk of cervical cancer, which is also a very, very big cancer in South Africa.
So focusing on prevention, which is, again, from a general health point of view, always the right approach. and being more aware of your risk and the risk factors. Now, what happens if we, in that situation, Dr. Rayne, you're in the area of surgery, so you really get to see it when quite, I would say, drastic, particularly in the case of a mastectomy or breast cancer. You then have to really operate, and it becomes I think this is the kind of thing that really scares a lot of women, and these decisions about whether you remove, whether you don't remove, I would say quite a challenging area. What are we seeing in that area which is positive and giving us a lot of hope in terms of recovery and in terms of treatments currently?
I think one of the most important things you say there is a lot of women are afraid that if they diagnose themselves or if someone diagnoses them with breast cancer, it will automatically lead to them having their breasts removed. And I think that's one of the biggest myths that we need to dispel, because a lot of times when cancer is diagnosed extremely early, it is possible to do minimal surgery in order to save the breast if that's what a woman wants, or to reconstruct the breast in a way which preserves the woman's aesthetic and leaves her feeling as whole a woman as she feels she needs her breasts for. So the old days where we used to take away the breasts and wish her luck have really gone. Nowadays, most women are suitable to have immediate reconstruction, which means by the time they leave the operating theatre, they have the same breasts as they entered. It may not be the same breast. Sometimes we take away the breast and replace it with silicone, and sometimes we can take away just part of the breast and move the tissue around so that women can even end up having a lift or a little change to the breast, which they often like. But it is possible in all circumstances to do surgery that doesn't disfigure a woman at all.
And again, we've been seeing a lot in the media about women who voluntarily now opt to have these operations, even if they don't have cancer, but they have a potential risk in their family, or they're just fearful because a granny or someone in the family had very bad breast cancer. Is that just, again, media getting carried away, or are we seeing something real happening in that area? Do you think there is this shift to kind of more surgical precaution?
I think there's two things going on there. The first is a very real realization that there is a certain amount of breast cancer we can prevent in women that have got a very strong family history. But that's a very small percentage of the population. Less than 10% of women with breast cancer will have had a genetic predisposition. Most women will have no family members who have ever had cancer before. But in that small percentage of women, by testing them for various genetic abnormalities, we can work out which women are at a very high risk of getting breast cancer. And in those circumstances, after very careful counselling, the path of a woman between knowing that she has a genetic abnormality and going ahead and having surgery can be anything between 6 months and a year. It shouldn't be something that anyone rushes into. The other people who tend to go towards having bilateral surgery nowadays are those that may choose it from a cosmetic point of view, or because they have a fear, which is often an unusual or not an accurate fear, that the cancer may come to the other breast. And that kind of fear is something that can be better dealt with good counselling and psychology than necessarily taking away the other breast.
Now we talk about psychology. Cancer as an illness, the psychology of the patient. So obviously got to play really a critical role in recovery or how they manage an illness like this. Do you have any thoughts to share? You both obviously work in that day to day and seen probably some amazing stories around this.
I think my positive patients who say, okay, what's the problem? How are we going to deal with it? And let's go with this. Who don't fight the process, often cope better with all the side effects that come along with the therapies that need to be done. So I think, being positive, being very optimistic, and having a good support structure, whether it's a family support, whether it's a sort of support group of breast cancer survivors, it's imperative that there is that support, that there is that positivity, because we've come such a long way, not only in surgical techniques, but in our oncological therapies. We've come such a long way in what we have to offer, where the outcomes have improved significantly. So, that positivity carries patients a long way, and it's always easier to get through the process if there's a good sort of support structure and a huge positivity around the patient.
One of the things I particularly love about our clinic at Helen Joseph Hospital, which is a public hospital, is when you see women in the counselling room being counselled by someone who has suffered from breast cancer and has survived. And the groups that you see, there may be a Muslim woman in a hijab next to a black African woman sitting next to a little Afrikaans lady, and together forming a group where they all have the same problem and they're all looking towards the diagnosis and treatment together. So it really does break down barriers in our society as well.
So support's really important in a process like this, and good mental attitude, which is very challenging, I'm sure, when you're really feeling terrible and you're very fearful.
I think one of the other important things to remember is that through treatment there's a lot of psychological difficulties, but it doesn't necessarily end at the end of treatment. 15 months after a breast cancer diagnosis, between 40 and 60% of women suffer some form of post-traumatic stress disorder. And it's important to remember that just because a treatment finishes, it doesn't necessarily mean a woman doesn't still need a lot of support.
She can't be on her own. And that is for any cancer victim, probably, anyone coming out of any of the other. If there's, just in closing, if you look to where we're going in society and medicine, are you hopeful as specialists in this area that we are going to really beat cancer in the long run?
Will we prevent cancer entirely from happening? Probably not. I think we're a long, long way from having a potential vaccine for every cancer, because not all cancers are necessarily virally related. But we've come such a long way in the treatments we've got available. And in that sense, yes, we're beating the fight, because we're allowing patients to go for earlier pickup with media awareness, with screening campaigns. We're picking them up earlier. We've got much better things to treat them with, and we are therefore able to say to them, you know what, it's not all bleak. Come sit in our clinics at the Joburg Gen, where patients basically, I mean, we see all sorts of patients of all walks of life, and in the private sector. Come, see how positive an atmosphere there often is in these oncology clinics. It's not doom and gloom, because we've got our survivors, we've got our 5 and our 10 and 15 and 20 year out, and we're getting better at doing that. We really
Fantastic. Well, that's great news to end off on. Thank you very much for joining me in the studio today. That's all we have time for today. Thank you for joining me for your weekly dose of health news. See you here next week when we will be talking about South Africa's obesity epidemic.